My name is Sophie Wallace-Hadrill, and this is my colleague Stacie. Thank you, Stacie Bowden. So we'll share the talk today, and we just want to say thank you so much for inviting us to talk to you. We're also really grateful to be part of a great team at the Evelina. I can see a number of our team members here. So all of the work that we do is very much possible because of the teamwork within the Evelina. So today, we hope to give you some information about our psychology service. There's lots of information in your packs as well, so we won't cover everything at the beginning. Give you an idea of the different roles of psychology, our referral pathway, and then I'll speak to the rationale for psychology assessments. Why do we do them? My colleague Stacie will then talk us through what's in our pre-transplant psychology assessment, and what kind of outcomes are there when we do these assessments. I'll then talk a little bit about how we work with our psychosocial colleagues, what challenges we face, and potential areas for growth. So originally, our posts were charity funded, now called Kidney Care UK. We represent the whole of the psychology provision for renal and urology within the Evelina, and we're embedded within the wider paediatric psychology team. So we have a number of different roles within the team. We do both inpatient and outpatient work and offer routine psychology assessments and intervention for example, procedural distress, adherence difficulties. And this is important to note as well, because a number of the referrals we might have would be young people who would be in the future coming up to transplant. So that it might not be immediately on the cards, but the team are aware that there are difficulties that are worth assessing with the young person and with the family to see whether there's any intervention that we can do preemptively to help them on their journey towards transplant. We're part of the psychosocial team, so we attend lots of psychosocial meetings in which we get a chance to discuss with our colleagues any kind of potential upcoming challenges or difficulties. And we also offer consultation to the medical nursing team. And when this is what we'll talk about, we offer pre-transplant assessments routinely for all families having a kidney transplant at the Evelina. So just to talk you through our referral pathway, so we're in the process of refining this. So we're presenting what our hopes are, as well as what our typical practice is. So for children aged 5 to 17, we ask that they have at least 2 sessions with the play specialists before they come for an assessment with us. So the play specialists are fantastic. They have lots of materials that are age appropriate to help young people understand what they can expect from the transplant process. With the parents, they will have met at least with the transplant coordinator. This is a relatively new role who's fantastic at being able to introduce the family all sorts of ideas about what to expect from the process of transplant, highly coordinated with the rest of the team as well. So our referrals come from lots of the team members, consultants, CNSs, or the transplant coordinator. We ask for information about the donor pathway, so whether it's a living-related donor, deceased donation, etc. The medical history, so we're aware, and any concerns that the team might have. They may well have told us in advance, we may well already be involved with the young person, but we just ask them to highlight to us so we know what to expect. In terms of the timing, we aim to offer an appointment at least 6 to 8 weeks, and ideally 3 months before they're coming up to transplant, so we can think about any potential difficulties with enough time to prepare young people for transplant. So why do we do pre-transplant psychology assessments? Well, it really gives us the chance to get a better understanding of their understanding, the child, the young person, and the family's understanding of the transplant process, what their expectations are, how ready they feel they are, and what resources they have for transplant. That might be resources as a family in terms of coping with the intensive experience that going through a transplant is. And we recognise that children and young people are very much embedded in lots of systems, the family system, the school system, the medical system. So it gives us a chance to invite those multiple perspectives of the young person to understand lots about where kind of potential areas of difficulty or potential areas of strength for this family are. It gives us an idea, if we don't already know, in terms of anything that might come up in terms of procedural difficulties or adherence difficulties, so that we're aware and can hopefully provide intervention beforehand. it allows us to assess those key things, and this was mentioned in talks before, that transplant is a long-term treatment, not a cure, and sometimes families have an expectation that this is a one-off, and this allows us to assess, do they have that expectation, or do they have a kind of realistic expectation of what's to come? Any distress that they might have associated with the physical changes that their body might undergo because of transplant, and their emotional well-being. How are they feeling about coming up to transplant, and do they need additional support? I will hand over to my colleagues.
Hi, so I'm just going to talk about how we do our assessments and what we cover. So generally speaking, for children who are 4 years and under, or children who have significant learning disabilities, we would aim to meet mostly with parents to do our assessments. For children who are 5 years and above, we would include children and meet with them directly as part of the assessment. And for our older children and our adolescents, we would aim to have some time with them on their own as part of that assessment process. Usually, in terms of the main areas that we cover, we would aim to start with a genogram or a family tree, which can give us a sense of what the kind of resources and family support looks like. We can also use this as a tool to ask a little bit about the quality of the relationships and the family functioning, a little bit about family history, perhaps particularly around mental health or psychological difficulties. And we can also ask a little bit about the relative stability of the family in recent years, any significant changes or stresses in addition to the medical condition. We then go on to talk about school, so we'll ask what does school understand about the child's medical condition and plan for transplant, and we can also then think about whether there are any learning needs that might be coming up at school that we need to be aware of as a team, and also it's a good opportunity to think with young people, particularly adolescents, how much they're talking to their peers about their condition and their plan for transplant. We then move on to talking more specifically about the hospital side of things. So in an age and developmentally appropriate way, we'll explore with children and young people what they know about their condition, about the kidneys. We'll ask young people and families about their experience of the diagnosis. We'll be asking about the history of operations and procedures, as this can give an indication of procedural distress, but also if there's any lasting long-term distress, which might indicate a trauma response for young people that we need to be aware of. And importantly, we'll also be asking about current medical management. We know that past behaviour can be a good predictor of future behaviour, so when thinking about how families will be able to look after a new kidney, it's important that we assess around the beliefs that they may have about the importance of medical management, but also the balance of responsibilities between young people and parents around medication taking, etc. And of course, a large part of what we cover is around the transplant specifically. So we begin usually by asking very practically what families' plans are for the transplant. And we'll then move on, depending on the age of the child, to explore a little bit about what they understand around the inpatient stay. So that could be about what they know about the cannula, the general anaesthetic, what lines that they'll wake up with in their body, how they feel they're going to cope with these things. And then we'll move on to kind of exploring a sense of what the child and young person and family understand about where the kidney's coming from. So what's their concept of deceased donation, if that's the route that they're taking, or perhaps if it's a parent or family member that's donating, how they might feel about that. We then move on to talking about life with a new kidney, and here is a really important opportunity to explore what hopes and expectations are of having a new kidney. And this can give us an indication whether families are fully aware of the chronicity of their condition, that they'll still be coming to hospital and taking medications and looking after the new kidney. We'll ask about the importance of immunosuppressant medications if they're aware of that. Perhaps particularly for adolescents, we're going to be asking about whether they're aware of the potential for there to be body changes with steroids and obviously with the transplant scar and so forth. And we do all of this sort of alongside additional parts of the assessment around mood and behaviour concerns, thinking in future about how those things might become more of an issue potentially with steroids in the future, post-transplant. We'll also take this as an opportunity to explore with families how they cope with stress and manage change. And towards the end of the assessment, we'll be asking families what kind of support they feel they may need, and if they feel that should be further psychology sessions, what that might look like. And we use scaling questions as part of the assessment to give us a sense of where families feel they are at with their readiness and their knowledge. And that can help us to plan future support for them. So there can be lots of different outcomes from our assessment. So sometimes from the assessment we'll go on to direct work with the child. We might work on improving treatment adherence before moving on to transplant, and we might use motivational interviewing ideas to do this. We might draw on cognitive behavioural therapy to provide anxiety management, or even graded exposure work to support young people with certain aspects of the procedure that might be quite worrying for them, perhaps the cannula for the general anaesthetic. And we also use narrative ideas to create stories and hospital books to help young people explore their feelings about having a transplant. We know that siblings are also very important and can be hugely impacted by the transplant process. And so we also offer siblings their own separate support, and that can be another outcome of our assessment. We'll also contribute to the development of inpatient support plans, which are essentially kind of recommendations shared with the nursing team around managing and supporting young people on the ward throughout their transplant, which is particularly useful perhaps for young people with neurodevelopmental difficulties who may have particular sensory or communication needs. And we also feedback our assessments. So we work very closely, as Sophie was saying, with our MDT colleagues. We write a written report of our assessment, but we also attend fortnightly psychosocial meetings where we can discuss our assessment, we can highlight the questions or concerns that young people might have. We might be able to raise any misconceptions or potential gaps in the transplant education pathway. And we can also then contribute to those more complex case discussions, perhaps where there might be undisclosed parental mental health difficulties or complex adherence difficulties. And very occasionally, our assessments will highlight some risk concerns, perhaps around the safety or well-being of the child or mental health needs, and we can then go on to make the necessary referrals. And of course, I think Sophie and I are struck many times by the resilience and incredible resources that our families have when we're meeting them, and so they may not need further psychology support as such. And so in that case, we would be closing them to the psychology service for the time being. I'll pass back to Sophie.
So we work very much as part of a psychosocial team. So I won't go through all of this, and it's in your pack, but we work very closely with our play specialist colleagues, the renal social worker, and I think we're very lucky to have a social worker within this area. We also work in neurology that doesn't have social work provision, and actually we really appreciate it within our work with the renal patients. The Evelina has parent counsellors as well, so parents wanting to kind of reflect on their own experience of the impact of having a chronically ill child, to have that available to them as well. We have the Evelina Hospital, so the hospital teachers we also liaise with, thinking about supporting young persons, siblings, while they're receiving education at the hospital. Our dietitians work very closely with families too, and we also have a music therapist. So all of these colleagues we work very closely with to try and make sure that young people are prepared as best they can for transplant and in the post-transplant period as well. So there are different challenges that we face. One of them would be, and this we're trying to iron out, the sort of timings of referrals. It's very difficult sometimes to tell, for our teams to tell us when they think actually the young person is going to be ready, as we heard. It's an incredibly complex process. So although we might say ideally we'd like it to be 3 months, actually sometimes it's very difficult for the teams to kind of coordinate. So we're kind of working on that and trying to refine that as much as we can. I think an important one is that families can sometimes feel that we are a sort of pass-fail service, that when you're having this assessment with us, that they might say the wrong thing or that they need to say the right thing. And we need to try and make sure that families understand that we're there to help prepare them and identify any areas of need for them, rather than being a gatekeeper for them to be able to have a transplant. There's also a balance of needing to assess what information they have, but also not provide that information. So if a young person or a family don't appear to know a certain crucial thing, we need to make sure that we are not providing that information because that isn't our role, but we then need to communicate to the team that further education or further information is needed around that, for example. There are other kind of challenges that we face, for example, when young people have complex conditions such as autism, trying to make sure that their needs are being met as best we can, and information sharing and confidentiality can present a challenge in terms of what families and young people want the team to know, etc. There are different areas of growth. This is all kind of rather ambitious, and we'd love to be able to offer even more extended assessments. So that 3-month point, it would be great actually if we could offer more than one 90-minute appointment, so that actually we meet with them on a couple of occasions to really kind of assess what they know at the time. It would be great to have met them a year before they were coming up to transplant, so that we could get to know this family, understand the kind of complexities of their life, so that actually when we meet them 3 months beforehand, we're much more familiar with them. It would be great to offer post-transplant assessments as well, to see how these families are getting on, whether there's any additional support they need. The teams will let us know. They're very closely monitored in the transplant clinic, so we do receive referrals where they're needed. But it would be great for us to offer that as routine as well. Introducing measures. We'd love to do that in a routine and meaningful way. So, for example, measuring the quality of life or mood measures, or more thorough cognitive assessments for young people. So we could even better tailor the information and the input that we're giving to them. So these are our this is our ambitious hopes for the future of psychology at the Evelina. So thank you so much, and we'd be happy to